Reporting from suburban Chicago, I'm Bill Groh.
Calcium pills may pose a heart risk. People who take calcium supplements could be increasing their risk of having a heart attack, according to researchers in Germany. Calcium is often taken by older people to strengthen bones and prevent fractures. Experts believe it should be taken with caution. They say promoting a balanced diet, including calcium, would be a better strategy. Researchers at the German Cancer Research Center in Heidelberg followed nearly 24,000 people for more than a decade. They compared the number of heart attacks in people who were taking calcium with those who did not. They found that people taking calcium supplements were 86% more likely to have had a heart attack. In other news, stress and depression may affect cancer survival. The author John Steinbeck said a sad soul can kill you quicker, far quicker than a germ. Several recent studies underscore how critically important it is for those fighting illness to learn how to combat stress. A team of researchers at the Integrative Medicine Program at the University of Texas MD Anderson Cancer Center found that symptoms of depression among a group of patients with late-stage renal cell carcinoma were associated with an increased risk of death.
Well, it's not a very attractive title, not about nothing. But anyway, did we make any progress with vaccine in other tumor type? I would say yes, and especially in prostate cancer, using T compared to placebo, it improves overall survival. And again, in metastatic melanoma, using ipilimumab compared to placebo, it also improves survival. So when we deal with immunotherapy or targeted vaccine in cancer, we have different kind of treatments, either non-specific stimulation via cytokine IL-2 and interferon alpha. We have also passive specific immunotherapy with antibodies such as bevacizumab, and we have also active specific immunotherapy, vaccine, and I will go into details, and also immunomodulator working on PD-1, CTLA-4, LAG, or TIM-3. So in order to have a vaccine which could target tumor-associated antigen, first of all, you need to have a criteria of selection for the TTA, lack of pre-existing tolerance, differential expression between tumor and normal tissue, immunogenicity, and a role in tumorigenesis. And in order to present as best as possible this antigen, you need to choose the antigen vectors such as peptide, dendritic cells, or viral vectors. So what kind of TAA do we have? We have TAA which are involved in differentiation, mutated antigen. We have antigen which are only expressed in cancer, and we have also antigen overexpressed in tumor. And here I have highlighted in red antigen that we have focused on in different clinical trials in renal cell carcinoma. So now, what are the results about vaccine in kidney cancer? We have, first of all, the vaccine trial, in phase 3 adjuvant trial. It's an autologous tumor lysis cell vaccine, which included M0 patient high risk of metastasis. The preparation of the vaccine comes from, the refractory, and 6 intradermal vaccinations were performed at 4 weeks interval compared to no treatment placebo. And here is the 5 and 10 years analysis. As you can see here, looking at PT3 stage 3 disease, it seems to have an advantage in terms of PFS of using the vaccine compared to placebo, but no differences looking at P2 or stage 2 patient. And going to the overall survival data, there is no difference, the p-value is 0.06. So now moving to the VT-SPIN phase 2 trial, it's a trial which looks at autologous tumor-derived protein peptide complex towards M0 non-metastatic patient high risk of relapse. VT-SPIN was given intradermally once a week for 4 weeks and every 2 weeks thereafter until VT-SPIN depletion. More than 800 patients were enrolled in this study, and the primary endpoint was recurrence-free survival. As you can see here, in the time to treat, no difference, but if you look at the advanced patient population, maybe a better outcome for those patients. But if you look at overall survival, no difference at all. So now moving to metastatic, a sitting Trovax trial. It's a vaccine towards, the oncofatal 5T4 antigen. It was MVA 5T4 versus placebo combined with cytokine or sunitinib in metastatic setting. Primary endpoint was overall survival. No difference at all, but maybe for some patients who had in baseline, normal baseline hematology, or for patients who had high 5T4 antibody, they could have a benefit from using vaccine. Now moving to TG4010 Phase trial in metastatic setting. It was a trial which was based on MVA expressing MUC1 and IL-2 alone or combined in progression with cytokine. 37 patients. The primary objective endpoint was objective response rate. No response at all for those patients, but maybe for some patients, around 30 patients had a stable disease lasting for more than 6 months. And the median overall survival was around 19.3. As you can see here, for those patients who had at the beginning a low level of anti-MVA antibody, they had maybe a benefit of using this vaccine. Now moving to the IMA901 study in Phase 2 in metastatic setting. It was IMA901 is a composition of 10 tumor-associated peptide vaccine. And in this study, patients were randomized to either placebo compared to chemotherapy, cyclophosphamide, in order to decrease the Treg population with this vaccine. And as you can see here about the overall survival, it seemed that to give a prior chemotherapy before vaccination could, induce a better outcome in terms of overall survival. Looking at the immune response, for those patients who had an immune response, they do better than those patients who did not have immune response, whatever, placebo or chemotherapy arm. Now moving to dendritic cells-based tumor vaccination, it was a nice meta-analysis performed by Drobe in 2011. It took into account 12 clinical trial. It's around 148 patients who had metastatic kidney cancer. And if you look at meta-analysis based on individual patient data, the objective response rate is around 30%. Clinical benefits 1 patient out of 2. And those patients who had an objective response rate, it was correlated to cellular immune response and the dose level of dendritic cells that was given to the patient. Now, just to summarize about vaccine trial in adjuvant or metastatic setting, besides the fact that maybe in the renal trial we may have a positive issue in terms of PFS, for the other trial it's quite disappointing. So now maybe this is due to the fact that for those trials we have used in fact either Wu or RECIST criteria, and now we should use immune response related criteria, because this is an example for a patient treated with ipilimumab. As you can see here, it seems that after a while we have a progression of the disease, but in fact we have a nice complete disappearance of the tumor. So we need time to let the immunity of the patient to get rid of the cancer cells. Now, what do we have in pockets about vaccine trials in RCC? We have 42 trials, 26 are completed, 8 unknown status, and 8 are ongoing so far. So let me detail those 8 open trials. So we have trials with anti-angiogenic drugs such as bevacizumab or mTOR inhibitor. We have trials with immunomodulator drug, and also we have other strategy using different kind of dendritics treatments. And one is a Phase 3 trial, the IMA901301, and I want to show you into detail about this trial. So it's patients who are randomized after first cycle of sunitinib to either chemotherapy plus vaccination and sunitinib for 4 months or sunitinib alone, and the primary endpoint of this study is overall survival. Now, how to improve immune response? First, vaccine trials show that immune responsiveness is predictive of better outcome, and targeting immunosuppressive by myeloid-derived suppressor cells and Treg and T-cell energy is a promising strategy. First of all, this is a study that we performed on sunitinib, which was found out to decrease Treg, and this was correlated to overall survival. As you can see here, after cycle 2 or cycle 3, there is a nice correlation between the decrease of the Treg and the overall survival. And it means that, first of all, Treg decrease could be a predictive factor, and also sunidipine could be associated with vaccination in order to promote, the immune system. And this is another other study, looking at all the effects of sunitinib, which can decrease the level of PD-1, IL-10, and CTLA-4, reinforcing the fact that maybe this drug could be associated with vaccine. So now, what do we know about immune checkpoint in RCC? We know that the antigen-presenting cells is going to interact with the T cell population at the TCR level, interaction between the CD28, leading to promotion of the T cell population, or you can, at the opposite, have the interaction with PD-1 or CTLA-4, leading to energy of this T cell population. So this is only a phase 1 study on the CTLA-4 drugs, EP, teclistamab, or this combination, which was too toxic. But as you can see here in kidney cancer, we have some tumor shrinkage, which were very interesting. Now moving to anti-PD-1, drugs, the MDX, it has been looked at in a phase 1/2 study. 18 metastatic RCC at different dose level, and as you can see here, very interesting result in terms either of tumor shrinkage or stabilization for a long period of time. So now moving to my take-home message, first of all, we have limited clinical efficacy of a vaccine in metastatic or adjuvant setting in renal cell carcinoma, but now we know better about better selection about tumor-associated antigen. We have emerging predictive factor. We have to focus on adjuvant disease. We need to take as a primary endpoint overall survival. We need to maybe to combine a vaccine with anti-VEGF therapy or immune control checkpoints such as anti-PD-1. And if you want to perform a vaccine-based clinical trial, you need to first assessment of immune response, evaluation of immunosuppressive pathway, third, use clinical radiological classification, and we are waiting for the phase 3 study, the IMMATIX trial. Thank you for your attention.
Initially, I will talk background. Regarding IL-2, similar select trial in patients with mRCC was reported by Dr. McDermott, who talks later. Retrospective analysis suggested that clinical characteristics and tumor features such as UCLA SANI score, clear cell histology, and CA9 could predict for IL-2 benefit. The study was conducted to prospectively confirm the above predictive models or factors. What is UCLA SANI score? Survival after nephrectomy and immunotherapy. And factors that predict survival and response to IL-2 were regional lymph node status, symptoms, location of mets, sarcomatoid histology, TSH level. Results. Neither clear cell histology nor staining for CA9 could predict for response to IL-2. Only UCL SANI score may identify patients who are unlikely to respond to IL-2. Result of IL-2 select trial were not satisfactory, demonstrating that it is difficult to prospectively prove the result of retrospective study. How about interferon alpha? In Japan, we urologists still use interferon alpha, especially for lung mets only patient, probably due to this result. This is overall survival of more than 1,400 patients with mRCC at the cytokine era. 5-year OS rate was 23%, excellent result. In addition, in our retrospective study, we reported association of SNPs of RS4796-793 that located upstream of STAT3 gene with interferon alpha response. In patients with CC genotype, 8 patients out of 10 were responder, whereas in GG patient, 4 patients out of 22 were responders. that was statistically significant, and odds ratio was 8.38. If we would use CC genotype of RS for 796, 798, 793 as a predictive marker of response to interferon alpha, on the assumption that response rate of interferon alpha is 15%, positive predictive value is 52.8% and negative is 88.2%. In addition, in our retrospective study, we showed 23 SNPs showed significant association with interferon alpha response. Among them, we select 11 SNPs and perform this study. The objective of our study is to confirm the correlation between the anti-tumor effect of interferon alpha and 11 SNPs of STAT32, STAT30, SOX31, etc. Japan Immunotherapy SNP study group for kidney cancer conducted this irRC select trial. Patients with mRCC who have measurable target lesions were enrolled and blood sampling was done, and DNA extraction was done by clinical laboratory company. 5-minute union of natural interferon alpha were administered 3 times a week and assessed the tumor burden every 12 weeks. Data collection and links SNPs data with clinical data, and we did statistical analysis. Inclusion criteria was an average one, and in patient characteristic, around 90% patients have PS0, and all patients received prior nephrectomy, and more than 90% patients have clear cell histology. And the most characteristic feature was site of metastasis. Around 70% patients have lung mets only. Probably because many doctors consider interferon is especially effective for lung mets. Totally, 211 patients were enrolled and 203 patients were eligible for ITT analysis. Response rate was 13.8%. That was reasonable, and CR rate of 4.4% was more than we expected. And 180 patients were eligible to analyze correlation between SNPs and clinical benefit because our protocol defined at least 12 weeks of interferon alpha treatment was indispensable for analysis correlation between SNPs and clinical benefits. At first, we defined SD as those without clinical benefits. The comparison was CR/PR versus SD/PD. However, none of the 11 SNPs examined was statistically significant. We next defined SD as those with clinical benefit. The comparison was CR/PR, SD versus PD. However, again, none of the 11 SNPs examined was statistically significant, but SNPs of STAT32 in SNPs of STAT32, p-value improved. So we next define the case as long-term SD if duration of SD is greater than 24 weeks. This method was used in phase 3 trial of temsirolimus reported in New England Journal. So in this case, cases of SD without record of assessment at the time of point between 20 and 28 weeks were excluded from analysis. However, if who had SD at the first assessment at 12 weeks and became PD before 20 weeks is short-term SD, and if SD and had recorded at second or subsequent assessment later than 20 weeks is long-term SD. So for this reason, 70 cases of SD were excluded from analysis. This is correlation between clinical benefit and PFS. Median PFS of modified clinical benefit using CR/PR plus long SD was clearly longer than that of conventional clinical benefit using CR/PR plus SD, demonstrating that modified clinical benefit can be a better surrogate for PFS. And the comparison this time is CR/PR long SD versus short SD PD. And in SNPs of STAT3/2, that was primary endpoint of our study, that was statistically significantly correlated with response to interferon alpha. Namely, in patients with CC genotype, around half patients were effective, and that was almost twice as that of in patients with TT genotype. Our result is response to interferon alpha was not associated with any of the 11 SNPs examined. However, when we assess patients with CR/PR and long-time SD as those with clinical benefit, and we evaluated the correlation, the significant association between STAT3/2 and clinical benefit of interferon alpha was observed. CC genotype of STAT3/2 was significantly associated with clinical benefits of interferon alpha. And this is the schema of interferon alpha signaling. STAT1 and STAT2 is phosphorylated in the receptor of interferon alpha and move into nucleus and works as a transcriptional factor and resulting in the overexpression of interferon alpha related gene. On the other hand, STAT3 located downstream of IL-6 receptor, and when phosphorylated, it moves into the nucleus and also works as a transcriptional factor and resulting in the overexpression of SOX. And SOX inhibit interferon alpha signaling. We think that is one of the reasons why STAT3 polymorphism is correlated with interferon alpha response. And this is prognostic and predictive biomarker in other solid tumor. In breast cancer, HER2/neu is a worse prognostic factor, whereas it is a predictive marker of response to trastuzumab. And c-KIT in GI stromal tumor is also worse prognostic factor, but it's a predictive marker of response to imatinib. And irRC1 in non-small cell lung cancer is similar. In mRCC treatment, there exist prognostic markers such as MSKCC criteria. So far, there have been seldom predictive marker reported. Also, Dr. Atkins yesterday showed excellent result of SNPs of molecular targeted drugs. Now, 2 cytokine and 4 molecular targeted drugs are available in Japan. When we use cytokine or molecular targeted drug, which order is good? Which combination is good? We have only limited information. Identification of a predictive marker for response to interferon alpha is the first step for personalized medicine in mRCC treatment. We believe this is the first prospective study demonstrating that STAT3 polymorphism can be a predictive marker in the treatment of interferon alpha for patients with mRCC. Thank you for your attention.
It's a great pleasure to me to speak here as a nuclear medicine physician to an audience of so many oncologists. But the topic the title of this topic is very interesting. As we all know, functional imaging obtained by positron emission tomography, especially performed by FDG, has been an established imaging method in oncology since the end of the 1990s. Lately, the combination of PET and CT in a single gantry system has been introduced with the advantages acquiring images in the same session, combining data of both techniques into co-registered images, and aligning, correlating the distribution of metabolic or biochemical activity in the body with anatomical imaging. So this has become a new challenge for the assessment of disease. During the last years, new cancer therapies have become more and more important, and we all know response rate must be viewed with some caution, trying to predict outcome. Lack of progression may be associated with improvement in outcome, even in the absence of major tumor shrinkage. Conventional imaging techniques and results criteria are usually applied based on changes on tumor size. Not able to early identify patients with a poor progressive-free survival during targeted therapies. So new concepts are under discussion for CT, for MRI, and of course for PET. But there's relatively little systemic integration of PET into clinical trials of new cancer therapies, probably because due to variable in study performance across centers, lack of uniformity accepted and practiced treatment response metrics of PET, and also accepted and standardized PET machine calibrations and quantification concepts. Recently, qualitative FDG PET reading at the end of treatment has been integrated into cancer response assessment of lymphoma disease, head and neck, breast, lung cancer. But quantitative measurements of tracer are a discussion because we have a lot of possibilities to describe and quantify these measurements. As standard optic values normalized to body mass, normalized to body weight. We can describe the maximal FUV as SUV90. But it seems to be very interesting for probably early induced therapy changes. Of course, the societies of nuclear medicine have taken some effort to define qualitative and quantitative approaches. For example, for the lymphoma disease, the UATC criteria, the PERSIS criteria, recently published in 2009, and also the standardization of PET and PET-CT protocols were established. So the assessment of response to anti-angiogenic therapy is for all imaging methods an ongoing challenge. FDG, as the most used tracer in PET tracer in oncology, has been investigated in renal cell cancer since the early 1990s with controversial data regarding staging and restaging, over sensitivities of 60 up to 100%, specificities of 80 to 100%. But I have to mention that all these studies have been elevated based on a single stand PET machine and not integrated PET-CT. The first publication established by at least a software-based co-registration of standalone PET and CT did not show any significant difference to conventional imaging techniques in recurrent renal cell cancer. And FDG seems also to be useful in post-operative surveillance, giving additional information up to 20% of patients or changes in therapeutic management in up to 11%. In the past, the low detection rate of primary tumor was always explained because of the high physiological tracer uptake within the kidney. I give you now an example how probably integrated PET-CT can overwhelm this problem. You have an axial view of an FDG PET through the left kidney. You see here the high tracer uptake within the kidney. On the left side, you have the corresponding contrast enhanced CT, and on the right side, diffused images. And beside the high tracer uptake within the urine collecting system, now you can also align this slight but focal tracer uptake here around to the tumor lesion found by CT. In the 1990s, there were also discussions and controversial data regarding correlation of tumor grade and FDG uptake. But more recently, the prognostic value of FDG pattern has been described with higher 5-year survival in FDG negative renal cell cancer. And this is a phenomenon we can also observe in hepatocellular carcinoma, for example, or the neuroendocrine tumors. So is FDG a surrogate marker of response to targeted therapies? I tried to summarize here some of the most cited and most interesting papers dealing with this topic. But what you can see here is small numbers of patients different treatment strategies, different imaging protocols, different treatment evaluation concepts, the time interval is different. So what can I tell you, what can I summarize? FDG-avid metastatic renal cell cancer patients with low uptake before treatment have a longer progression-free survival. Higher FDG uptake and increased number of lesions seems to correlate with a shorter overall survival. And a decrease of up to 75% of FDG uptake in soft and skeletal metastases were observed. What about FDG PET and conventional imaging techniques? There was a clear discrepancy of response evaluation between PET and CT after 2 cycles of therapy, decrease of FDG uptake but unchanged number of lesions after some weeks of treatment. What about FDG and prognosis? Patients with partial metabolic response or stable metabolic disease seems to have improved prognosis. And a significant decrease of FDG uptake early after start of therapy seems not to be prognostically relevant, but the PET results after 16 weeks, as you can see here, published by Kayani et al. in 2011. The scan prior to therapy, 4 weeks after the start, with a decrease of FDG within the tumor lesions, but 16 weeks later, new lesions were discovered. Besides FDG, there are also some other very interesting traces. For example, carbon-11 acetate. It's a surrogate of lipid metabolism in the cell membrane associated with tumor growth. And there are few studies in renal cell cancer with unfortunately inconsistent results regarding detection of primary tumor metastasis. But there were really strong limitations because of different study protocols, fasting time, injection dose, scanning time, and so on. So probably this seems to be an interesting tracer for further studies. And there's a very interesting case report of sunitinib response showing acetate response to this therapy by acetate in an FDG-negative renal cell cancer patient. Here an example performed at our institution in a patient with metastatic renal cell cancer. On the left side, the acetate data, on the right side, the FDG, and you can see here pathological tracer uptake within the mediastinum, quite corresponding to the FDG result. But we can see also here focal tracer uptake in the rib, in the oosacrum, corresponding to very small osteolytic metastases shown by CT. And also here, in the region of the left kidney, 3 hot spots corresponding to the tumor lesions in the left kidney. Another very interesting tracer is FLT. It's a marker of tumor proliferation. And in 2011, there was a very interesting publication showing an increase of cellular proliferation found by FLT PET imaging during the withdrawal of sunitinib therapy. And they concluded that this is consistent with the VEGF receptor tyrosine kinase inhibitor withdrawal flare. So let me summarize and conclude. PET and CT in a single gantry system improves the anatomic location of abnormal tracer accumulation and the highest staging accuracy than PET or CT alone. Positive FDG PET is predictive for the presence of renal cell cancer and complement anatomic imaging modalities. The FDG uptake within a tumor lesion and the number of lesions seems to correlate with prognosis, and treatment-induced metabolic changes in FDG-avid metastatic renal cell cancer seems to be prognostic. There is some evidence that other tracers such as acetate or FLT have an impact on restaging, staging, and therapy assessment in renal cell cancer. But for further studies, we have to consider some aspects. Larger study populations accepted of standardized or PET imaging protocols and treatment evaluation concepts. The timing of imaging seems to be a very important question, and we should not forget probably combinations of different imaging modalities, but not only PET and CT or PET and MRI, probably combined with diffusion-weighted MRI, but also combining different PET tracers but also imaging modalities with laboratory tests. Thank you for your attention.